Manish, you had a presentation at ESMO. We're talking about all these new agents that are out there. We just heard from Ian about a new antibody. Tell us about STAT3.
Yeah, so STAT3. It is an essential protein that is often phosphorylated and activated in several cancers, including gastric cancer. And it is a feature that actually provides stemness, a feature that allows cancer stem cells to become active, proliferate, and also somewhat resistant to chemotherapy. It also has immune properties as well. So activation of STAT3 actually inhibits the immune infiltrate from penetrating as well. So for the first time, a company named Boston Biomedical has a STAT3 inhibitor. And so that is now in a phase 3 study in the second-line setting. It's called the Brighter study. And I think that that is a real potential to add one more drug to our armamentarium.
I love it. I love it. Now we have to learn about stemness. We learned about
Yes.
immunotherapy. We still have more development going on along the HER2 pathway. Pertuzumab.
Absolutely. Well, we've had the advantage of building on what has been known in breast cancer for decades. You know, trastuzumab has been around for gastric cancer since 2009, but unfortunately, we're not certainly curing patients, and the majority of the patients progress after less than 7 months on therapy. And so the idea is to build on targeting HER2 with pertuzumab, which is also a monoclonal antibody that binds at a different site of the binding domain of HER2. And this is the trial that is currently ongoing, it's a randomized fashion, looking at the TOGA regimen, which is 5-FU trastuzumab, with or without pertuzumab. So the study hopefully will be reported in the near future, and we're awaiting the results. It's not prime time yet.
Yeah, so we follow breast cancer yet again. We've got to
Right.
get ahead of them at some point in this HER2 story.
There's one other trial I should mention, I think. This is the matrix metalloproteinase inhibitor.
Yes.
We've, Brivinib was actually the original one maybe 10 years ago. And this class of drugs was limited because of toxicity, fatigue. But Gilead actually has a drug, which is an MMP9 inhibitor that has shown actually very encouraging results in the first-line setting. And so they've moved on to a phase 3 study as well. So the drug development is, again, accelerating in upper GI cancers.
I mean, so interesting, the way that I try to describe it to patients with the matrix metalloproteinase inhibitors is that to be able to grow or to invade, the tumor's got to break down its surrounding
Right.
area, and this helps it do that, and particularly seems to be effective for gastric cancer patients.
And it comes back to what Ian said about modifying the tumor microenvironment and how that could actually have profound effects.
So much going on right now, new research. Ian, I wanted to catch you. You gave a wonderful discussion on a new study that was just, had some expanded results presented at ESMO of a new antibody for patients with gastric cancer. Can you tell us a little bit about that?
Yeah, so there is a new target, in fact, called Claudin 18.2, which, going back to TCGA, in fact was identified in the genome stable subtype, which is more associated with diffuse histology. And they actually identified that it can form a fusion protein and drive the biology into much more aggressive diffuse histology. And this is found mainly in gastric mucosa and gastric cancer, not in the rest of the body. So it does seems to be a very good target in gastric cancer. The company that generated a monoclonal antibody called IMAP362, and they've done a study where they randomized patients in a randomized phase 2 setting of standard chemotherapy, which they use epirubicin, oxaliplatin, and capecitabine, EOX, with 2 different doses of this IMAP362. And what they have seen is, first of all, the primary endpoint is an improvement in progression-free survival, which they did find a significant improvement at the median level is almost a 3 months difference. But more importantly, when in the overall survival, which is using the original dose, which is 800 milligram bolus, loading dose followed by 600 with each cycle of EOX. They also find an almost 5 months improvement in overall survival. And in this year's ESMO, what they presented is the second arm where they use a 1,000 milligram per kg of the antibody in conjunction EOX, and they showed both the progression-free survival and the overall survival. And again, the manageable benefit actually is probably slightly less than the lower dose, but nevertheless, it's still compared to the control arm, there was a significant improvement. But I think this is a randomized phase 2. We in the past have been disappointed by so many times for so many encouraging randomized phase 2 that then didn't read out in phase 3. And also one thing of note is the control arm do not seem to be performing as well as one would expect. Because obviously we got large body of randomized data of EOX in both real 2 and then real 3 data, so we know what that drug should do on the what it says on the tin should be what it does, but it seems to be less good in this particular study. But maybe because as I said, this is mainly in a diffuse histology, although they haven't actually shown data to say of the patient recruited, how many patients were classified by Lauren classification as a diffuse histology. They use their biomarker assay and they have to be tested positive to go into the study. So it is a biomarker-driven study. But I think it is extremely important that they confirm these results in a large-scale phase 3 study, again, powered up for overall survival, and as I said in my discussion, conducted in different geographical regions.
This has been extremely informative. Before we end this discussion, I'd like to get final thoughts from each of our panelists. Dr. Chau.
So I think we already talked about how important nowadays with knowing more about the molecular characteristics of the tumors in our patients. And I think really taking that forward, we really need to look at how we can integrate that information and look at agents that may be more working in the microenvironment, angiogenesis, immunotherapy, and how to make the tumor more visible to the immune system, how to make our all this treatment work better. And I think that really is a goal that we integrate all this information to try to improve the survival of our patients more.
I love it. Dr. Janjigian.
Well, one thing we know about gastric cancer is that it's a very molecularly complex disease, and because of the nature of the epithelium and where the tumor is located, it will be important to find combination therapies, targeted agents that will help us control the tumor if we ever want to move away from the cytotoxic chemotherapy. Unlike other molecularly driven tumors, it will not be one switch, one target model, and we really need to move toward treatment strategies that combine different biologic agents for them to work better together. There's a lot of development, a lot of interest in the scientific community, and what I tell my patients, even in my lifetime as an oncologist, there have been new development and 2 FDA-approved drugs just in a very short amount of time. It's important to study this disease, to study it in the setting of a clinical trial. Enrollment in trials is important. And ultimately, make this a chronic illness, a potentially curable illness.
I love it. Dr. Shah, you got the anchor man.
Third again.
Yes.
No, so I think that what's really clear is that the drug development has really accelerated in gastric cancer. In the last 10 years, we have 5 new drugs that have been approved. I think as we move forward, we need to learn how to sequence the drugs and combine them in a better way, in a smarter way, understand the molecular profiles, and be proactive in terms of managing the patient's side effects and all together, I think with that, I think we can really improve outcomes, improve their quality of life as they continue with this disease.
I love it. See, you did beautifully, even though you had to be anchor man last up. I love it. So thanks to all of you for your contributions and this discussion. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thanks so much.